All right. Good morning, everybody. Sorry that we're starting a little bit late, but we will go to about 25 after 10 Eastern Standard Time this morning. Thank you for joining us as always. And welcome to Ask Dr. P Live. Today we have a 65 plus edition lined up for you. This isn't just the school games, this is an hour of Ask Dr. P on school games. We've been running Asking Dr. P to bring the heat, drop real knowledge, and help people win the game of life pain-free, surgery-free, and full of motion. Dr. Marc Pietropaoli, aka Dr. P, is the founder and CEO of Victory in Motion, home of knee repair, not knee replacement. Over the past 34 years, he's built a totally unique trademark system that uses your body's own healing power plus regenerative medicine to relieve pain, restore and optimize function, and help you crush your goals without metal, plastic, or cement in your joints. Dr. P trained with the GOAT himself, Dr. James Andrews, the orthopedic surgeon behind names like Bo Jackson, Drew Brees, and RG3, just to name a few. So trust us, this man isn't playing around. He's here to change the game for real people like you, folks who want to walk again, climb stairs again, garden, dance, hike, and win back the life they thought they've lost. His program delivers 80 to 95% of the time. Satisfaction rate 94%, baby, backed by Data Biologics National Registry. Today, we will go lightning round again. We took your questions from school games, social media, and the vault, dropped them in the chat GPT, and created the ultimate list of 100 rapid fire questions about knees, lasers, bone marrow, fitness, faith, food, etc. We've got 60 minutes, we've got 100 questions. We're going to run the table. Dr. P, are you ready?
Yes, Allison. Thank you for the intro. Hello, everybody. And yeah, let's get started.
All right, let's go. First question up. Can knee pain over 65 still be reversed?
Yes, knee pain over 65 can still be reversed. We do it every day.
What's the number one reason people over 65 tend to avoid stairs?
The number one people that we see over 65 tend to avoid stairs is due to pain in their knees or lower extremities or back.
Is it ever too late to start a joint program?
It is never too late to start a joint program, meaning to help the joints get better and feel better and move better.
In terms of arthritis, is it common for pain to come and go?
So, in terms of arthritis, is it common for pain to come and go? And the answer is yes. It is common for pain to come and go, wax and wane. And it's usually more stiff in the morning. Uh, as you get going throughout the day, it loosens up. Then it might swell and be sore in the evening. That's just kind of a generic timing, but that's kind of the way it waxes and wanes. Yes.
Should joint pain be expected with aging?
Should joint pain be expected with aging? It becomes more common, but it shouldn't necessarily be expected. So it's not necessarily, quote, normal. It's something that we can help and oftentimes get rid of.
Can bone on bone pain improve without surgery?
So can bone on bone pain improve without surgery? And bone on bone is just kind of a generic term. I don't even really technically know what bone on bone pain is. I think we're talking about arthritic pain because bone on bone means the cartilage on the end of the bone has worn down or is wearing down. The space is narrower. And instead of having cartilage, a nice smooth surface, if it does get to literally bone on bone, when there's no cartilage left, that's pretty severe or significant arthritis. But even in those circumstances, many times we are able to get people better and either avoid surgery or delay surgery or at least help their pain and improve their function, their range of motion, swelling, etc.
Do stiff knees always mean that they are arthritic?
Do stiff knees always mean that they are arthritic? No, that's not
All
always
right.
coming from arthritis. There's lots of different reasons the knee can get stiff.
Can aging cartilage regenerate with bone marrow and PRP injections?
Can aging cartilage regenerate with bone marrow and PRP injections? All right, so a little complicated, but the bottom line is um, PRP, platelet-rich plasma, has growth factors, which helps with healing and it helps stimulate cells. to work better. Bone marrow aspirate cells has actual cells that do the work, but those cells, those stem cells and other cells that help the stem cells, but especially stem cells, the stem cells tell other cells what to do. So the more cartilage you have, the better those are going to work, no matter what, because the less severe the disease, but also the more cartilage cells you have. Because the white you see on the end of a chicken bone, that's not all cells. There's cells in these little lacunae, so kind of like it's almost like kind of honeycomb, but there's not a lot of chondrocytes or cartilage cells there. What the cartilage cells do is they produce a matrix, glucosamine, chondroitin sulfate that people eat. That is part of the matrix. There's different proteins and actually long sugars, believe it or not, that make up the white stuff, the actual substance of the cartilage. So the PRP in the bone marrow work well to help those cells work better and produce more matrix. But they're not great. PRP definitely doesn't do this, but even bone marrow, when you're putting cells in there, there's very little evidence that those cells completely stick to the end of the bone and grow back a whole new bunch of cartilage. It's really more they tell those other cells what to do that are already there, and they make them work better and produce better matrix and more matrix. And so the cartilage can get a little thicker. There are some studies that show that, but I don't think we're really good at putting cells in there and having those cells stick and rebuild by themselves. They help other cells do their job better.
Thank you.
So in essence, by the way, just as they also, and I know we're taking some time here, but those the PRP and the stem cells can help other cells act younger, believe it or not. So that's another thing that they kind of do. It kind of makes your cells act and work like when they were younger better.
Awesome. Thank you. Okay. What's the biggest red flag in an aging knee?
What's the biggest red flag in an aging knee? I mean, I think the biggest red flag is the most common one is pain that's not going away after a few days or pain that's constant. It's just chronic. It's there for weeks or months. That is a big red flag that something abnormal is going on. Swelling and stiffness and progressive loss of range of motion are also red flags. But I mean, pain is it. That's the number one red flag, I would say.
Absolutely. All right. Is it normal to have pain in both knees at once?
Is it normal to have pain in both knees at once? Well, it's not normal to have pain in either knee, first of all. But can you have it in both knees? Absolutely. I'd say it's still a little bit more common to have it in one as opposed to both, but it's probably 60-40, about 40% of people or, 30 to 40% of people have pain in both knees, even if one is much worse than the other. And it may be even a little higher than that too.
All right. Are bone marrow and PRP injections safe after the age of 70?
So are bone marrow and PRP injections safe after the age of 70? Absolutely, yes.
All
We still
right.
have great bone marrow cells in our pelvis into our 80s studies have shown. But safety-wise, yeah, they're very safe no matter what age.
So, what makes regenerative medicine work well in older adults?
What makes regenerative medicine work well in older adults? Guess what? It works well in any adult or even a kid. So the younger you are, the better it is going to work. But what makes it work well in elderly people is that we still, our bodies still have the ability to heal ourselves. So maybe our platelets don't work as well and they don't have as many growth factors, or they don't function as well. So instead of one PRP, platelet-rich plasma injection, it might take two or three. What we've even found is dose is more important than the amount of injections you get. So just you might have to draw more blood to get a higher dose in an older person, but you can still be very effective. So dose and concentration are more important than frequency, although frequency might be even high, a little higher as you get older. And then we still have very good stem cells in our bone marrow in our pelvis. Now, in our arms and our legs, we don't have very good bone marrow as we get older, less cells, and that's why we start to break down. But we have good bone marrow cells in our spine, in our pelvis. The pelvis is an easy place to get stem cells from, to harvest them, concentrate them, and then inject them into the areas, let's say around a knee, where we've don't have as many stem cells anymore, especially in the bone. If you inject them into the bone, we can get that bone to heal and cure that problem in the bone. Bone has millions of pressure-sensitive nerve fibers, and when the bone's starting to break down, you're getting a little stress or microfractures in the bone because the cartilage over the top is wearing down, and other reasons, getting a little bit more overweight, putting more stress on the joint. Our bones are a little bit weaker as we get older, osteoporosis, not eating as well of a diet, all those things, and decreased muscle mass, they add to more stress on the bone. But we can take good cells from the pelvis area, right underneath the skin, above the butt area. It's not the hip, it's not the back. Take those, inject them right into the area where they're lacking, and help that area heal, reseeding the areas in essence.
Next question, very similar. You basically just answered it, but I'll say it anyway. Do results differ between a 65-year-old and an 85-year-old?
So the results from PRP and bone marrow aspirate cells differ from a 65-year-old to an 85-year-old. It depends because I mean it can differ from a 25-year-old to an 85-year-old. Depends on how healthy that person is, how many cells you're able to get, what the dose is, all those things. But in general, I don't think the results are that much different on average between a 65-year-old and an 85-year-old. They can be very good results, but they're maybe not as good as if you're 25, but they still can be very, very good.
All right. Can you treat joint degeneration that is more than 20 years old?
Can you treat joint degeneration that's more than 20 years old? Well, I think joint degeneration comes from kind of wear and tear over the years anyway. So most of the time, as it's degenerated, it's probably even over 20 years old. But maybe you're saying, or maybe the question that they're asking is if someone's had pain for 20 years or known joint degeneration for 20 years, can we still help that? And the answer is absolutely yes.
And are outcomes still good after age 75?
So you're saying our outcome's still good for PRP and bone marrow and other regenerative medicine techniques after the age of 75?
Yes.
Yes, outcomes are still and can be very good. We don't just do a shot though, so that's the other thing. Like you really want to address all those other issues I was just talking about. We want to make the person stronger, so make their do strength and conditioning exercises to build their muscle mass because we know that helps as you get older. Also lessens the risk of falling. Lots of makes your bones stronger. That's important. Weight bearing exercise is important. Impact loading exercise within reason to build the bone strength up because as we get older, our bones get a little softer, especially females. Losing weight. For every pound of weight that you're overweight, you're adding 3 or 4 pounds of extra force across your joints. If you can drop 10 pounds, that could be 30 or 40 pounds less force going across your joints. That's going to make you feel better. So what you eat, you are what you eat. If you eat an inflammatory diet, it's going to make the inflammation in your joints worse. So we have a genetic-based plan, goes by your genetics, decreases the inflammation. So we treat the whole. We don't just treat, I think people are asking, does PRP or bone marrow work and get good results after 75? It does, but we don't just do that. We do a whole program,
Absolutely.
which stacks the odds more in your favor.
What's the oldest patient you've helped avoid surgery?
The oldest patient I've helped avoid surgery is over 100. We had a gentleman in here, I think he was 103, and we helped him avoid surgery, and he did very, very well.
Yes, he did. How soon can someone 65 or older feel relief after undergoing bone marrow and PRP injections?
So, how soon can someone 65 and older feel relief after PRP and bone marrow injections? It can be. There are a few people who and claim that as soon as we gave them the injections, they walked out and they felt better. We absolutely have had that. Some of that could be there is an initial anti-inflammatory effect for PRP and for the bone marrow. But I would say, most people, the first 3 days are pretty sore because we're kind of restarting the healing process. And the first 2 weeks are probably the quote worst, although nowhere near what a surgery is, because I've had surgery and I've had uh, the bone marrow and the PRP on my elbow. Big difference. So 3 days, pretty sore. 2 weeks, the kind of the most improvement in recovery. And then after 2 weeks, most people are starting to already feel better. Most people feel better before then, but I'd say 3 days to 2 weeks, you should start feeling better already. But by 6 weeks, most people are 50 to 90% better. By 12 weeks, we know 80 to 95% better. It's not 100%.
Do you feel or have you found that patients who are over the age of 65 need more than one round of the bone marrow and PRP injections.
So the question is, do people over the age of 65 need more than one round of PRP and bone marrow injections? In general, no, especially doing bone marrow. I can't recall repeating that on anybody, frankly. PRP sometimes, but again, I think the more we know about PRP, the more we know that you just have to collect more blood to get a higher dose and then concentrate it down even more. So the more concentrated the PRP and the higher the dose, the higher the number of platelets. Like for a knee, for instance, 10 billion platelets. So bare minimum 60 cc's of blood drawn. But if you draw 120 cc's, you can almost guarantee that you're going to have enough platelets to have a very nice effect and only maybe need one injection versus two or three.
All right. Can laser therapy be combined with these injections for better results?
So can laser be therapy be combined with PRP and bone marrow injections? Absolutely, we do it all the time. I mentioned all the other things we do as well as like the total body fitness and the nutrition, but laser is amazing. It decreases inflammation, increases healing, increases blood flow, has a direct pain relieving effect. It stimulates the mitochondria, which are the little powerhouse of your cell. So the better your mitochondria work in your whole body, the better you work. And so the mitochondria are really the powerhouses of all our cells and where we get our energy from, our ATP. So without mitochondria, we're dead, literally.
Now, in terms of osteoporosis, does that affect outcomes at all?
So does osteoporosis affect outcomes of regenerative medicine procedures? And I'd say in general, no, meaning you do the procedure on somebody. I mean, osteoporosis doesn't necessarily cause pain unless you fall and you get a fracture because your bone is so thin, or you get a stress fracture because your bone's so thin or weak. So in general, I would say that osteoporosis does not have an effect on regenerative medicine procedures. We do tailor the programs to help build muscle and build bone, so we can help reverse that. There are hormonal ways to do that as well, which we will be getting more into bioidentical hormone replacement therapy. That's a whole nother subject that we could talk for hours on. But those things can all help osteoporosis. But osteoporosis shouldn't necessarily negatively affect or inhibit someone from doing regenerative medicine procedures.
Okay. And this one, again, you pretty much just answered it, but it does say, can weak bones or osteoporotic bones increase knee pain?
So, can osteoporotic bones increase knee pain? And in general, the answer is no. Now, the osteoporosis means the bones are less dense, which means they're weaker. And so they are more prone to stress or microfracturing or even macrofractures. If you fall, break the hip, break the wrist, uh, break the spine. So they're more at risk of that. But yes, we do see people with stress microfractures in their knees because the cartilage wears down, more and more force gets transmitted to the bone underneath. Bone has millions of pressure sensitive nerve fibers, so it gives you pain. So if you have osteoporosis, you probably are more likely to get those stress or microfractures. Although, frankly, you and I should look this up. I don't know definitively if there's ever been a study done to look at that, like people who have osteoporosis, if they're more prone to get stress microfractures, but it only makes sense. And if there is a study, I apologize, but I will go look that up. We'll have it for the next talk.
Absolutely. All right. Somebody in their 70s, should they be worried about the development of osteoporosis?
Should someone in their 70s be worried about the development of osteoporosis? Well, yes. Somebody young like you should be even more worried about it because you still have the ability to build bone. People have the ability to build bone into their 30s in general, young 30s. So that's really the most important time. Now, after that, people in general start losing bone mass, females more than males, and females absolutely after menopause more than males. And so by the time a female is in her 70s, absolutely, she's probably been at least 20 years into menopause. And so it is something to be concerned about. Hopefully, being concerned about osteoporosis before then and doing things like weight bearing exercise, eating the right diet, getting into your doctor, getting checked out, getting a DEXA scan, regularly with your primary care doctor. those are still all extremely important. But to answer the question, yes, if someone's 70, and especially if they're a female, they should be aware of and concerned and tested for and possibly treated for osteoporosis if needed.
Okay. What do you think the best supplements for bone health are?
So, what are the best supplements for bone health? I think you've got, and again, here's what I would say. Definitely talk this over with your own doctor. Don't just start taking vitamin D and vitamin C, which, by the way, those two are hugely important for bone health. I mean, people take protein supplements. I mean, I think if you eat a good enough diet and collagen, because collagen's in, in our bones and throughout our whole body, different types of collagen. So there's all kinds of different supplements, but the two most important for bone health in my mind would be vitamin D and vitamin C. There's others, but those would be the two most important. And definitely speak to your, get tested for osteoporosis and speak to your primary care or your OBGYN or your bone health specialist.
All right. How can those over the age of 65 help to improve their balance?
How can people over the age of 65 help improve their balance? Um, Believe it or not, our eyes make a huge difference for that. So making sure you got the right glasses, if you do have glasses, making sure you're wearing them. I mean, honestly, a lot of people, when their vision goes, their balance starts to really go, downhill. So I think that's an underrated one that people don't think of. But then there's a lot of strengthening exercises that can be done. There's simple balance exercises that can be done that can be taught by any physical therapist. All physical therapists learn that type of stuff. There are, if someone has an inner ear problem, there are simple exercises to help that. So I would say a physical therapist would be a great person to talk to about that. Also talk to your primary care doctor. But the physical therapist can not only strengthen your muscles, make you more steady, um, but can also assess for any fall risks like throw rugs and cords and things like that, help you going up and down stairs. And then also if there's any inner ear or balance issues. And then if it's your eyes, obviously see your eye doctor and make sure you have the best possible vision you can because that makes a big difference. And then at night, put your glasses on. If you get up to go to the bathroom, don't not put them on because then you're more at risk of falling. And have a night light, by the way, too, because even if you have your glasses on, it's completely dark, then effectively your eyes aren't working, and your eyes are a big part of your balance system.
All right. Can a undergoing a regenerative program reduce fall risk?
Can undergoing a regenerative medicine program reduce fall risk? And the answer is absolutely yes. And I can only speak for ourselves. I don't necessarily think, well, if you just did shots and made the knee pain better, if someone has knee pain, they are more apt to fall, right? And stumble or buckle or whatever. But you said program, and I like that because a program is not just the shots. It's also strengthening the muscles, getting the range of motion back, getting the mobility back, making up for any deficits or imbalances. If it's the knee, you might need to work on the back to help that person's balance and their knee pain as well. So, and even what we just talked about, physical therapists can do a lot of. We do balance training and things like that with our people who go through the programs, especially if they already have a known fall risk or they have issues with their balance, known issues with their balance already. But even if they don't, we help improve that. So definitely going through a full program can decrease the risk of falling, which is great.
And do you feel that adults 65 and older should do some sort of balance training on a daily basis?
Do I feel that people 65 and older should be doing some type of balance training on a daily basis? The answer would be yes, if possible, definitely.
I agree. Do you feel that falls are a sign of poor joint function?
So are falls a sign of poor joint function? The answer is they can be, but there's a lot of other reasons for falls too. Like people can just not have, they might have a throw rug, they might have bad shoes, they might be walking in the dark without a night. So there's those are like things that are easily preventable. And then there's the the vestibular system. There's all the things we just talked about, eyesight,
Mhm.
muscle strength, mobility of the joints. If you're stiff and you're walking with a limp, you're more prone to fall. If your shoulder, even if your upper body doesn't work, if your arms don't move well or your shoulders are really stiff, we use our arms to balance. And so we actually see people who've had surgery on their shoulder and they're in a sling and they can't use that arm for balance, actually at more risk of falling a lot of times than the people who have a knee surgery and they have crutches and they have, they're already being trained on how not to fall. So upper body affects balance just like lower body does.
What about the feet? Do you think focusing on strengthening the muscles in the feet can help to reduce falls in general?
Can strengthening the muscles in the feet help to reduce falls in general? Yes, I do believe that. Our feet, that's probably an underrated a thing that isn't taught very well, but our feet do have a lot of muscles in them and they help grip and they help with our balance. And so that wouldn't be the only thing I would recommend, but that would be part of a fall prevention program. Yes.
Okay. Shifting gears a little bit, are cortisone injections safe for people 65 years and older?
Are cortisone injections safe for people 65 years and older? All right. I hate cortisone, by the way. I think people know that already if you've ever watched me. I mean, in general, is a cortisone shot pretty safe? It is, but it's not as safe as a PRP, a platelet-rich plasma injection, and it's definitely not as safe as laser, where there's no needles, no shots, no known side effects. Very, very safe, cleared by the FDA since 2009. So, cortisone shot, you're over 65. What if you have diabetes or don't know you have diabetes? It can make your blood sugar go up. We've actually seen people who were diagnosed with diabetes because they got a cortisone shot. It made their blood sugar go up. They got lightheaded, et cetera. They had to go to the emergency room. They got tested, and their blood sugar was like 500, and it should be below 100, right? So though that it can cause systemic side effects, which aren't good. It can cause, we know there's studies that show it causes faster wear and tear of the cartilage in the joint. So why would you want to put something into an arthritic joint that's already wearing out, that's going to make it wear out even faster? There's studies that have shown people who get cortisone injections, that knee will wear out faster than if you don't get cortisone injections. Um, it makes you at a higher risk of infection. It makes healing less likely. So if someone had a rotator cuff problem or a shoulder problem and they had a cortisone shot within a year, and then they had to have surgery within that year, it makes the repair much less likely to heal. And if it does heal, much less likely to stay healed and more likely to tear. So it makes it like 25% more risk of not healing and tearing. So cortisone has a lot of potential side effects and risk factors that, in my mind, aren't worth doing. And it's really technology from the 1800s. It's
Exactly.
it's crazy.
So, gel shots, as many people know them as, or hyaluronic acid, can they be effective in knees over the age of 65?
So, can gel shots, hyaluronic acid injections, be effective in patients over the age of 65? And the answer is yes. Our joints have joint fluid, and to lubricate them, all our joints have that. And the primary component of our joint fluid is hyaluronic acid, which I know is used in beauty products and other things as well. But it's a very slippery substance, very lubricating. And so, by adding hyaluronic acid into a joint, it can thicken up the fluid, but it really what it does is it gets absorbed by the body usually within 3 to 5 days, and it stimulates the joint to produce better fluid. So it tends to last longer than a cortisone shot. It's definitely safer than a cortisone shot, but it doesn't really heal the underlying problem. If there's a problem in the bone, it doesn't do anything for that. And a lot of insurance companies are not covering it anymore. But in general, it can help, but it's not earth-shattering, but it's safer than cortisone, and I would definitely recommend it over cortisone. Now, it is artificial. It could come from rooster combs, believe it or not. Or if you have a chicken or feather allergy, then there are genetically modified bacteria that produce it. So it's kind of made in a lab or made in a factory. So it is artificial, which is a bad thing. I like PRP, platelet-rich plasma, because it's your own blood. I like bone marrow cells because they're your own cells. We're using you to help you heal you versus using something made in a lab artificially.
Yes, and Next question up is if someone who is planning or wants to undergo bone marrow and PRP injections, can they do that if they're on a blood thinner?
So can people who are on a blood thinner undergo PRP and bone marrow injections? In general, we would prefer they not be on a blood thinner, just like if they had a surgery, only because it makes you at a little bit more risk of bruising and getting what we call a hematoma, which is basically a blood collection or a larger bruise, especially where we harvest it from, which is pretty much right under the skin, above the buttock area and the posterior superior iliac spine, which is part of your pelvis. Injecting it into a joint usually isn't going to be a huge issue. Injecting into the bone could cause more bruising and oozing as well. So for that reason, we like to have people off a blood thinner. A lot of times, blood thinners like aspirin are anti-inflammatory and affect platelets as well. In general, the blood thinners don't necessarily affect the platelets releasing their growth factors because platelets can release their growth factors through several different pathways, one of which is just injecting it and being them exposed to collagen, which we have in our whole body. So usually they're going to activate, release their growth factors. But if they're on an anti-inflammatory slash blood thinner like aspirin, or even ibuprofen can thin blood and cause decreased inflammation. We're trying to restart the healing process. So for the first couple of weeks, inflammation is a normal part of the healing process. So we don't want them on it for that reason as well. Having said that, there are people who, have to be on a blood thinner, and we usually get clearance from their doctor to see if they can come off it. And if they can't come off it, you can still do it. It's just a higher risk of bleeding and oozing, and maybe depending on what the medication is, how much anti-inflammatory effect it has, it could affect the results negatively a little bit, but it can be done. And you have to sometimes, choose the lesser of two evils, or be it, safety first, knowing you might not get as good of a therapeutic effect. But in general, we like to have people off their blood thinners. Um, Depending on which blood thinner it is, anywhere between 3 to 10 days ahead of time. And usually they can restart blood thinners the day after. Um, if it's aspirin, we try to make it 2 weeks after if that's possible. But again, we get clearance through whether it's their cardiologist or their primary care or their hematologist or whoever has them on that blood thinner. We talk to them, and communication is the key.
Mhm. All right. In the same vein of medications, can laser therapy replace medications or help people get off some medications?
So, can laser therapy replace medications or help people get off medications? Yes, because laser does several things. It stimulates the mitochondria, it increases blood flow to the area. There are some medications that can do that, um, but it also decreases swelling and inflammation. So, anti-inflammatories do that, but laser does it without any of the messy side effects. You take anti-inflammatories by mouth, it can rip your stomach apart, it can affect your kidneys, it can affect your liver, it can thin your blood, it can affect your platelets. It can affect the healing process. Laser uh, has none of those nasty side effects, no known side effects.
All right. Thank you. Is strength or flexibility more important in people who are over the age of 65?
So the question is strength or flexibility more important in people over the age of 65? And I think that's a great question. I think they're both very important and different. There might be someone who's very strong who's not flexible at all. And you might have people who are very flexible who aren't very strong. So I guess it depends and there's other things too, more than just flexibility and strength. There's mechanical things. There's a lot of other things involved. But as far as if I had to pick one, I think technically strength, I would pick strength over flexibility if I had to pick one. But they're both important.
Okay, somebody who knows they have knee arthritis, should they walk every day?
So for someone who knows they have knee arthritis, should they walk every day? If they're not having pain walking, absolutely. There's nothing, if it's not causing increased symptoms, their knees not swelling up, they're not having pain, maybe they're a little sore for a day or two after any exercise, after exercise. That's pretty normal. The soreness should be getting better. But now, if they're walking and they're getting a lot of swelling in their knee or a lot of pain, then no, they should get checked out.
All right. Are resistance bands safe for people 65 and over?
A resistance band safe for people 65 and over? Yes, if prescribed and taught properly.
Can hip pain be confused for knee pain or vice versa?
Can hip pain be confused for knee pain or vice versa? Knee pain, so all right. So a problem in the hip can absolutely cause pain or the sensation of pain, referred pain in the knee. Absolutely. You don't see it as much where something in the knee is causing pain, like indirectly causing referred pain in the hip. That doesn't really happen. But can an issue in the knee cause abnormal mechanics or issue more stress on the hip and vice versa? Absolutely. We see it all the time. So someone has a really bad arthritic knee, that's going to cause them to limp. They might get stiffness. That could affect their hip, put extra excess stress on their hip, on their ankle, on their feet, on their back, and vice versa. The back can cause pain in the knee. The hip can cause pain in the knee. The ankle doesn't directly cause pain in the knee, but the ankle t tightness or the ankle not allowing you to roll over, it causes more stress on the knee and indirectly causes increased knee pain. So they're all related. That's why we treat the whole body. We don't just treat the knee by itself.
All right. And what about the back? Can that be kind of confused or misdiagnosed as knee pain or vice versa?
So can the back cause pain in the knee or can the knee pain be misdiagnosed underlying back pain and or back issues? Because some people have no pain in their back, but their back is actually causing their knee pain because of an irritated nerve or things like that. So we don't we usually see both. Like there's a lot of people we see with knee pain, and it turns out they have back pain too. So now they have two problems, and how much of their knee pain is being caused by their back. We had a lady recently who had arthritis in both knees, mild to moderate, but there for sure, not bone on bone like she was told. But when we worked on her for her back, 90% of her knee pain went away. So most of that quote knee pain was being caused by from her back. We have other people who you get their back better and their knees are still killing them. Well, then most of it's probably coming from the knees. So you have to ferret that all out. But again, taking care of the whole person and not just the knee by itself or the whatever injured part or painful part there is. Because you're absolutely right. Quote unquote knee pain can come from many different areas, many times not from the knee itself.
Yes, in dovetailing on that, do you feel that, people with knee pain should also get their back checked out as well?
So do I feel that people with knee pain should get their back checked out as well? Yes. The evaluation should be, the whole body if you can, but the least back and down if you're looking at someone for their knee. But we do tend to have our VFit team, our Victory Fitness team, total body strength and conditioning team look at people from head to toe and do a full body evaluation to figure out where their issues are coming from and what things we can work on.
Can regenerative therapies and programs help the hip like it helps the knee?
Can regenerative therapies and programs help the hip like it helps the knee? Yes. They can help any joint, any area of the body that's been injured
All
or
right.
painful or has dysfunction.
Should people over the age of 65 avoid kneeling?
So should people over the age of 65 avoid kneeling? I would say uh, if it's bothering the person, I would avoid it. If it's not bothering them and they have to do it for certain things, like maybe gardening or going to church or washing the floor. I mean, a knee pad helps. It's not going to necessarily help the arthritic part of your knee, but you have your skin and you have bone and there's bursa in between there, and that can get inflamed. So I think knee pads help. It does take some of the force off, even for the arthritis. But if you're getting pain while kneeling, you probably shouldn't do it. And you probably shouldn't kneel and twist at the same time. That would not be good. And kneeling for prolonged periods of time I don't care how good your knees are, that can tend to sometimes, give people symptoms and aggravate things and put excess stress on the knees. And I did tear my meniscus kneeling in the garden weeding many years ago, so I know that well.
Yes, all right. So how does somebody with joint pain know that they're like compensating with improper biomechanics?
How does somebody with joint pain know that they're compensating due to abnormal biomechanics? And some patients kind of do know that because they say, "Hey, my ankle's stiff, or my hip's stiff, or my back." They'll say other areas are bothering them. But I think the best way is to get evaluated by um, a musculoskeletal specialist. So that might be an orthopedic surgeon, that might be primary care, sports medicine. Um, Primary care doctors in general are not great at musculoskeletal. They have to know a little bit about a lot, so they don't know in depth as much. So that's where like a physical therapist is usually going to be way better than your primary care in evaluating if you have any other underlying contributing conditions. Um, so I would highly recommend a musculoskeletal specialist like an orthopedic surgeon, and or a physical therapist, a doctor of physical therapy.
All right. Somebody 65 and older, wearing a knee brace help them to stay active?
Can wearing a knee brace help a somebody who's 65 and older stay active? If they have an unstable knee due to torn ligaments, yes. If it's just because they want to wear a brace, the answer is maybe. Most people really don't need braces, and we discourage braces in general because then the people rely more on the brace, or the knee relies more on the brace, less on the muscles, and the muscles can atrophy, or they don't bend or straighten the knee as much with a bulky brace on there, or even a non-bulky brace. And so you might lose some range of motion and have some stiffness. So in general, we don't like braces. And so there are people who it just makes them feel better. Maybe the knee's a little warmer. Maybe it just makes proprioception, meaning just position sense, it makes them feel better. So in some people it can help, but if you go to the right physical therapist, or like in our case, VFit specialist, take care of the whole body, most people don't even need come close to needing a brace, and they prefer that. It's just they thought, hey, it's not their fault. They thought, hey, if I go buy a brace, they see all these ads on TV, that's going to help my arthritis, and it might temporarily, but a lot of times it's doing more harm than good, making your muscles weaker and your joints stiffer.
Yes. Can somebody cancel a scheduled knee replacement at the last minute?
Who asked that question? But of course, can you cancel a knee replacement last minute, or cancel any surgery last minute? Absolutely. I've had it happen. I'm a surgeon. I've had people cancel last minute, or I've had to cancel them last minute. Maybe there's a cut or a scrape on the leg, or a sign of infection, or they're sick from some other reason, or someone just doesn't feel comfortable, or maybe I look at their, something, and like, hey, man, that actually looks like it healed. And then we're like, hey, maybe we don't need to do that. So yeah, you can always cancel last minute until you're completely under. I've never had this, but I've heard of people being canceled right on the table, like somebody right before they get the anesthesia, they quote unquote chicken out and say, I don't want it. Great. You don't have to have it. You can't force someone to do it if they don't want to. So the answer is yes, you can always cancel a surgery at any time, for the most part, I suppose, unless you're already asleep, um, at any time.
All right. So if somebody is experiencing joint pain, should they wait to see how things go or move fast, especially if the pain starts to worsen?
So if somebody has joint pain, should they wait to see how things go, which we tend to do, or should they get in and be seen right away? If that pain is getting worse over 3 days instead of getting better, if it's present for more than 3 days, or if you are waiting, it's been there 2, 3 weeks. I mean, yeah, no, that's not normal. So definitely get in to see somebody, at the very least, your primary care. But if you can, get in to see a musculoskeletal specialist, like a lot of places do have direct access for doctors of physical therapy or orthopedic surgeons. Get into that office, or a primary sports medicine primary care, or a functional medicine doctor. There's a lot of doctors you can see who can help you with that.
All right. What are the risks, particularly with knee replacements, especially as people age?
What are the risks of knee replacements, especially as people age? So, especially as people age, they tend to have more medical problems, diabetes, heart problems, lung problems, and things that can lead to heart attack or stroke or pneumonia or infection or uh, whatever flaring up and getting worse, whether it's a rheumatologic condition because they have to be off their medication or diabetes. All those things are at a higher risk as you get older. But the biggest risks of any surgery are always infection. Most surgeries, it's still less than 1%, but that's still one out of 100. And so someone is going to be the one, and an infection in a joint replacement is a disaster. So that's a very dangerous thing. You can certainly continue to have pain. It's not uncommon to have some numbness and tingling in the front of the knee after knee replacement, stiffness, soreness, the knee may be wearing out, and needing another replacement. That's always a risk. Um, the risk of falling while recovering. I think I said wound healing problems. Sometimes the wound doesn't heal, needs to have further surgeries. Um, Maybe the person, everything heals and looks great, but they still have pain. 30-40% of people who have knee replacements still report some discomfort or some pain. So you obviously have seen a lot of people. Any other risks you can think of as well? I mean, well, how about an allergy to metal, right? We have somebody we were just talking about
That
yesterday.
would be a big one.
He had hip
Absolutely.
replacements done, and he came to us for his knees, and he's got allergies from his metal and his hip replacements, and it causes his skin reaction and pain, and it's not good.
Not at all. So if somebody undergoes a knee replacement and it fails for whatever reason, can regenerative therapies still work afterward?
So if someone undergoes a knee replacement and the knee replacement fails, can they still undergo regenerative treatments? It depends on what we mean by failure. So if it's loose and needs to be replaced, regenerative medicine treatments like PRP and bone marrow cells and laser are not going to help that. If it's that failure means it's still painful and it's stiff, but it's not loose and it's not infected. Absolutely. We help that all the time. Laser helps great with that. But we've injected PRP and bone marrow around the soft tissues to loosen that area up. Putting it into the metal and plastic knee probably isn't going to help a ton, but
Mhm.
it could a little. It can help the lining of the joint be less inflamed, etc. But injecting all those tight tissues and stiff tissues and scar tissue around the knee using laser, using total body fitness. I mean, again, even though you got a knee replacement, sometimes the back and the hip are contributing to that pain. And like, oh, the surgeon's like, everything looks perfect on the X-rays. You have good range of motion. Your knee's fine. I don't know why you have pain. Well, anybody ever check the person's back or their hip or maybe their ankles causing increased stress on the knee? So there's a lot of other reasons that we can help a quote unquote failed knee replacement work better. And we do that all the time.
Mhm. Can somebody with a pacemaker still undergo laser therapy?
So can somebody with a pacemaker still undergo laser therapy? Yes, except for directly over the laser, and even that is theoretical, but it is not. There is an FDA warning: do not use laser over the pacemaker. So you do not want to use it over or around the pacemaker. But if you have a pacemaker and you have knee pain, well then yes, you can use it on the knee. It's far enough away from the pacemaker that it will not cause a problem. And even again, it probably would not cause a problem even if you did use it over the pacemaker, but we do not because we are not allowed to, and we want to be as safe as possible.
Hmm. Okay. For patients who undergo our regenerative therapies, do you find that older adults progress slower than younger adults or people of a younger age in general?
So, for patients who undergo regenerative medicine programs, do older people progress slower than younger people? In general, I would say not necessarily. I mean, some of these, I got to say, the older women, they're tough. They like they you know. you might have a young 18-year-old young man be way more pain or resistant or um, non-compliant than an 80-year-old woman. Or I'm just using those as two examples, but I think the answer to that question is not necessarily. Age doesn't necessarily always negatively affect recovery in regenerative medicine procedures, and it also depends on what that person wants to be able to do. An 80-year-old might just want to have no pain, doing laundry, standing up, cooking, walking up and down the stairs. An 18-year-old might want to get back playing high school soccer or college soccer. That's different. So it depends on what their goals and their demands are as well, as far as quote recovery goes.
Absolutely. Can our patients bring their spouses, family members, or loved ones to their appointments?
So, can our patients bring their spouses, family members, loved ones to their appointments? We pretty much even almost demand that in the beginning. Like when we first see somebody, we really want a loved one, a supportive person, their support person, their spouse, whoever that may be there because we call it a clarity day because we give them a lot of information and they're here for like 4 or 5 hours getting evaluated and tested. And at the end of the day, we go through a very comprehensive report of everything and we go through their goals and then we present them with three pretty darn comprehensive programs that they can choose from. So having that person there to support them for the day to learn. I mean, who wants to get evaluated for, let's say it's a few hours and go home and re-explain all that, right? If the person's there, you
Exactly.
don't have to explain anything. They saw it all, and so it just saves time. It's more efficient, and then it also avoids any confusion because they don't have to go home and explain it, and so it also helps make the decision. Most I'll just use spouses for example. They consult each other as to, should I do this or should I not do it? And it can work many ways, but they're a team and it's great to have them there together to make that decision together. And even if it's, quote unquote, just a friend, well, that's important too, because the same thing, your friend's going to ask you a million questions. If they come and they watch, they don't have to ask you any questions. They'll know, and so I think it's just a great thing that we almost, like I said, we pretty much almost demand it.
Yes. Do you adjust your programs, your regenerative programs, based on someone's activity level?
Do we adjust someone's regenerative programs based on their activity level? Yes, and but really more so their goals. I mean, most people want to get more active. So, oh, this person is not very active. We're going to adjust the program. It's not necessarily more that. It's more like, hey, where are you starting from? Where do you want to go? And we'll
Mhm.
adjust there.
How long should somebody rest after undergoing bone marrow and PRP injections?
So, how long should somebody rest after ongoing bone marrow and PRP injections? And I guess everybody's definition of rest is different. So take it easy that first day, working on some range of motion. But the first day is really just chill out after you get home. And then the first 3 days are the most limited. But we do want people getting up, we want them moving around. I mean, it's not like you had a knee replacement where you're pretty incapacitated those first few days. And even then, with a knee replacement, we want you getting out of bed that day and or the next day. So we get people moving pretty quickly, but you can get moving even quicker than you would after a surgery because this isn't surgery. It's really more very minimally invasive with just poke holes and needles instead of big incisions and scalpels.
All right. And after undergoing the bone marrow and PRP injections, should someone use ice or heat?
So after undergoing bone marrow and PRP injections, we are trying to restart the healing process. So should you use ice or heat? We don't like people using ice in the beginning because it is an anti-inflammatory and it will slow down that initial good inflammation. Acute inflammation for the first week or two is technically good for the healing process, and we are restarting the healing process. So we don't want to inhibit that. So we strongly discourage ice use. A warm pack sometimes help, a heating pad, but most people don't even do that. Tylenol you can take. The harvest site where we harvest it from on the pelvis above the buttock area, you can ice that all you want.
Okay. And somebody asked, can I drive myself to the procedure?
So can I drive myself to the bone marrow PRP regenerative medicine procedure? You can drive back and forth, but in general, we don't encourage that. Now, there are people who will get a little sedation while they're here, then they definitely 1000% cannot drive back home. So that's a definite. Um, if they have not had sedation, and it's a body part that shouldn't prevent any issue with driving. Sometimes we'll be okay with it, but bottom line is bring somebody, you don't have to worry about it. And I'd say 95 to 98% of the time, we want somebody to drive them back and forth.
Okay. Are electric bikes a good option for people 65 and older?
Our electric bike's a good option for people 65 and older. If you ride a regular bike, and you like doing that, I mean, technically that's better exercise, but there's a lot of people who um, want to get out. They maybe their area is hilly, or they know they want to go someplace that's farther than they could probably bike to. I think the electric bikes are really cool. I've used them a few times, and you can set it to just ride it like a regular bike, or you can set it to just,
Hmm.
go like an electric, just go all electric. Most people do a little bit of both, which is nice. So you can get some exercise. Yeah, if you're going to use it, I would set it where you're going to at least do some pedaling, for sure. Otherwise, what the heck, get a motorcycle. Maybe
All
it's
right.
more exciting. Now, I didn't say that because motorcycles, we see a lot of bad injuries with motorcycles, as orthopedic surgeons. So we struggle with motorcycles, whether they're good or bad. They're
I
definitely
agree.
bad orthopedically, but it is what it, if you have it. So can a bike be, and so can anything
Yeah.
be, but motorcycles especially because of the speed.
Yes. Do you feel that hydration is more important as people age?
Do I feel that hydration is more important as people age? I think it's important no matter what. I think being more conscious of it and careful of it as you age, because not every person 70 or 80 should be drinking an ounce of water per pound of body weight. That's kind of your general ideal amount of water to drink in a day. I mean, if you're 180 pounds, that's 180 ounces of water. That's a lot of water. So even if you go zero point 0.5 um, ounces of water to every pound. So a half of an ounce of water to every pound that you weigh. If you're 180 pounds, that's still 90 ounces. That's a fair amount. So some people are on diuretics or have issues with their heart, and they should always talk to their own doctor about what the right amount of hydration is for them. They might have kidney issues, they might have electrolyte issues. So you do got to be careful, and we got to be careful when we tell people to quote stay hydrated, but we do want them hydrated as best as possible the day of the procedure because it does absolutely help with the harvest. But even we got to be careful. Does someone have kidney disease? Do they have heart disease? Are they on medications, diuretics? So they're going to be like just in the bathroom all day long, peeing, that type of thing.
Yeah.
So you still got to be careful, but your generic hydration rules are, you know, zero point 0.5 to 1 ounce per pound of body weight per day.
Okay.
I mean, another
Have
thing
you
is you could
helped?
just drink.
Oh,
You
sorry.
could drink till your urine is not clear. So dark yellow is bad, and clear is bad. Somewhere in between, lighter yellow is better. Then you're kind of hydrated. That's
Yes.
another way you can just test.
Good rule of thumb there. Okay. Somebody asked, have you helped people get off a walker or a cane?
If we help people get off a walker or cane, yes, all the time, almost every day.
Yes. Can you help somebody get back to dancing?
Can we help people to get back to dancing? Yes, all the time.
Okay. Should I get a second opinion before I undergo knee surgery?
Should I get a second opinion before I undergo knee surgery? It depends on what your trust level is with that doctor. If you've been with that doctor for years and years and years and years and you trust them, great. Like, and trust them. But if there's any questions whatsoever, always. I mean, we even say, like, we have people say, "Oh, I'm not sure." Okay, go get another opinion. That's fine. Get two opinions. We're going to tell them everything that we need to tell them. And if they want to get another opinion or two, we never discourage it. Even though we like to, think we're the experts, it's okay for people to get other opinions. And so if you feel you have any hesitation whatsoever, go get another opinion. Yes. Even with us, if you're with us.
Okay, nearing on almost up to the 60 minutes here, but one last question. Do joint replacements last forever?
Do joint replacements last forever? Joint replacements are made out of metal, plastic, and cement. Not all of them are cemented, but artificial stuff. So anything artificial is going to wear down. Even though it's hard metal and it's hard plastic, it does wear down. On average, depending on age, the younger you are, the more active you are, the more you weigh, et cetera, the quicker it's going to wear out. But on average, probably 15 to 25 years. If you're younger, it might only last 10 years. If you're older, it might last 20, 25, 30 years. But in general, I'd say 15 to 25 years, they quote unquote last. Now, remember, once you get it, you're stuck with it forever. You're stuck with artificial forever. So if it doesn't work, if you're one of these people who, after 2 years or 5 years, even 10 years, it's worn out or it's not working, you're going to have to get a revision. And those are a lot more risky, a lot more painful, a lot less successful. And so if you do need a joint replacement, you want it to push it out as far as possible without letting other things like your medical condition, et cetera, worsen. But as far out as possible so that that first one you get is hopefully your last one. And that's another thing we'll do. Some people know they're going to get a knee replacement, but they're 40 or 50s or they're in their 60s and they want to push it out. We can really help a lot with that. I remember one of the first patients I ever saw in my whole career was 44. We got him to 66 before he ever needed his knee replacement. So hopefully he'll never need another one.
Exactly. Okay, well, that concludes our session for today. Dr. P, thank you so much for answering all the questions. As always, very great and thorough explanations. Thank you to everybody who continues to submit their questions. Please remember to like, follow us, tell your friends, family, coworkers, anybody that you feel may benefit from our services about us. As always, we will see you next Wednesday around 9 a.m. Eastern Standard Time. And we look forward to chatting again with some great new topics.
All right, Allison, awesome job. Thank you. And thank everybody for their questions and for tuning in.
Thanks, Doc.
See you next week.